question is that if we assume that the patient has a multifocal dystonia and in the same time has a Parkinsonism, could that be indicative for a structural cause in the basal ganglia? And the answer is no. Multifocal dystonia is very common in Parkinson's disease itself, and is also very common in atypical neurodegenerative Parkinsonisms, such as MSA or PSP or CBGD and so on and so forth. So for a structural lesion in the basal ganglia will be a secondary Parkinsonism. So either there's a stroke in basal ganglia, or iron accumulation, or carbon monoxide poisoning, or hemorrhage or bleed or something like that. And for that to cause Parkinson's, there is no one single pattern to tell you, okay, this is something that is indicative of structural lesion. There are some tips here and there, something that you see more in NBIAs, or something that you see more with a carbon monoxide poisoning and so on and so forth, and stroke and so on. But it is not a one unified or a standard model where you can use and say, okay, if these things are present, then it's very likely that it's a structural cause. A structural cause can present with a typical Parkinson. Patient may look like typical Parkinson, not even dystonia, just like a regular Parkinson, and there may be a tumor in the brain, and there may be extra fluid in the brain. So I use red flags on history and on examination to try to say, okay, I need to do MRI of the brain. So a red flag on history would be, number one, rapid progression that started 6 weeks ago, and they already have a UPDRS score of 37 or 40. So you expect a UPDRS score to increase by 5 to 7 points a year. So if someone has, they notice Parkinson when the score crosses 20. So if someone has, let's say, a baseline score of 25 and they are 37, that means at least 2 years of disease. And if you see that in 6 weeks or 6 months, then that's atypical. Similarly, lack of response to medication. If it looks like Parkinson's and they are taking 600 or 800 milligram of levodopa a day and they have no benefit whatsoever, then that's concerning, and so on and so forth. So there are many red flags. That lecture that I mentioned, atypical Parkinsonism examination technique, that's a really, really nice lecture that tells you a lot about those red flags to look for. But something that we can go in more detail someday on what are the red flags in Parkinson's. When Parkinson's disease is, when someone presenting is not Parkinson's disease. So what is unusual? What will not fit in a regular Parkinson's disease? Someday we can talk about those more specifically. But I think that lecture covers a lot of it. Okay.